Hi and welcome back to another video of Medic Notes. This video is on clavicular fracture. Midshaft clavicle fractures are common traumatic injuries caused by a direct impact to the shoulder girdle and is most commonly seen in young, active adults. Diagnosis can be made radiographically with API and cephalic tilt clavicle X-rays. Treatment is non-operative or operative based on patient activity and demands, along with degree of displacement, shortening, and comminution. For epidemiology, it is common, seen in 1 in 1,000 people per year, account for 2 to 4% of all adult fractures. It is often seen in young active patients, less than 30 years old. 75 to 80% of all clavicle fractures will occur in the middle third segment. For mechanism of injury, usually patients fall onto the lateral aspect of shoulder, or can be due to direct impact to the clavicle. Junction of the outer and middle third is the thinnest part of the bone, and prone to fracture with axial loading. The middle third of clavicle is the only area not protected by, or reinforced with muscle and ligamentous attachments. For displaced fractures, they are usually due to medial fragment pulled postero-superiorly by sternocleidomastoid muscle, or lateral fragment pulled inferomedially by pectoralis major and weight of arm. Open fractures usually result from medial fragment, buttonholing, through platysma. Clavicular fractures can be divided into non-displaced and displaced, shown in these pictures. Further classified into type A simple, type B wedge, and type C complex. A1 is simple spiral, A2 is simple oblique, A3 is simple transverse. B1 is spiral wedge, B2 is bending wedge, B3 is fragmented wedge. C1 is complex spiral, C2 is complex segmental, C3 is complex irregular. For presentation, patients usually complained of popping or cracking sound near shoulder after fall. Symptoms are acute onset of anterior shoulder pain or directly over clavicle. On inspection, there will be tender, swelling, crepitus, and deformity over clavicle. Skin tenting suggests impending open fracture. For neurovascular exam, we have to assess subclavian vessels and brachial plexus. This picture shows skin tenting in a case of clavicular fracture. For imaging, clavicle series include upright API clavicle, and 15 degrees cephalic tilt using the Zanca view, shown in this picture. Shoulder X-ray can also be done to evaluate for other injuries. Possible findings are superior displacement of medial fragment, inferior displacement of lateral fragment, or shortening. Measurements for shortening. API clavicle, measure distance between the corresponding ends of the medial and lateral fragments. API chest, direct comparison of length of clavicle to the contralateral side. Shortening more than 2 cm associated with decreased shoulder strength and endurance. For displacement, it is relative to width of clavicle. More than 100% displacement is a risk factor for non-union. There are some indications to do CT scan. To assess fracture pattern for pre-op planning, when there is vascular injury, medial clavicle fracture, or SC joint dislocation. Treatment can be non-operative or operative. Non-operative will be sling immobilization. Indications are less than 2 cm shortening and displacement, or less than 1 cm displacement of the superior shoulder suspensory complex. Closed and no neurovascular injury. And low-demand patient. Techniques are sling, or figure of -8 strap. Figure of -8 is associated with more pain, shortening, and lower compliance than sling. There is no difference in functional or cosmetic outcomes between sling and figure of 8 braces. Whereas operative treatment is open reduction and internal fixation. Indicated in open fractures, displaced fracture with skin tenting, subclavian artery or vein injury, or floating shoulder. Techniques include intramedullary fixation, or open reduction internal fixation with plate and screws. Operative fixation has higher union rate, similar or better functional outcomes than non-operative, and faster time to union. Complications for non-operative treatment is non-union and malunion. Operative management also has complications, like hardware prominence, neurovascular injury, supraclavicular nerve injury, non-union, infection, mechanical failure, pneumothorax, and adhesive capsulitis. That's all for this video. Thank you.